Hi, welcome to AETCM. Today we are going to discuss a case about a 74-year-old male who was brought to our ER with a history of left hypochondrial pain for the past 3 days. Sir. So, on initial assessment, the patient was conscious, oriented, and able to complete one full sentence. So, the airway was patent and no secretions was noted. And coming to breathing, air entry was decreased on the left side. Normal vesicular breaths were had, and respiratory rate of 20 per minute was noted. Saturation of 98%. And coming to circulation, the BP of 120 or 80 with pulse rate of 78 per minute, and all peripheral pulses were palpable. And disability GC score was full with pupil of 3 mm equally reactive. And exposure temperature was 98 degree Fahrenheit with GRBS of 168 milligram per deciliter, and patient was covered to prevent hypothermia. Adjacent to primary survey, GRBS of 168 and ABG showed no acid-base rearrangement, sir. ECG was normal sinus with heart rate of 77 per minute. Coming to secondary survey.
In a patient who is having reduced breath sound on one side, what are the differential diagnoses?
Sir, can be pneumothorax.
It can be pneumothorax. Then
Pleural
effusion. Then
collapsed lung.
Collapsed lung. Okay. So if the patient is asymptomatic and there is reduced breath sound on one side, among all these three, what is the possible diagnosis?
Pleural effusion.
Pleural effusion. Whereas in pneumothorax, even if it is slightly older, means 1 or 2 days back, he might have developed pleural effusion. There also you'll have some amount of breathlessness. Collapse also you'll have breathlessness. But why in pleural effusion they don't develop breathlessness?
Because there is enough. First of all, the other part of the lung is functioning, and this part lung also.
Pneumothorax also other part is functioning.
No, sir, but it'll, only if the pleural effusion becomes massive is when the patient expansion is still possible.
It is because of the compensation on the opposite side. Since pleural effusion is a progressive disease, it may take 1 or 2 weeks to develop like this. Okay. Whereas in massive hemothorax, pneumothorax, or collapse, all these things are an acute condition. So opposite side or upper part compensation may occur. It will take some time. That's why in most of the pleural effusion, even if it is a larger effusion, you don't get much findings. That is because they develop compensated emphysema on the opposite side. What is compensated emphysema?
Hyperinflation of the alveoli in compensation to the pathogenic lung. So
how it is different from emphysema?
In emphysema, it's a pathological state wherein the alveoli get hyperinflated and they lose their ability to recoil. So, because of that alpha antitrypsin deficiency, they will not be.
Emphysema can be due to so many conditions. One is alpha 1, but it is in the physiological space. The pathological is not in the physiological. It can cross the physiological space and it can go to the pathological area. Means it can expand beyond the limits. But here it will be in the limits. So you don't get any clinical findings of emphysema. But when you're taking an X-ray, you can see some findings of emphysema. Okay. That's why most of the patient who is having larger pleural effusion also, they don't have much clinical symptoms. Only while examining you see symptoms, or they can have breathlessness, cough on walking, okay, or exercise.
So in secondary survey, a 75-year-old male, non-case of CAD, status for PTCA, complaints of left hypochondrial and left infrascapular pain for the past 3 days and was associated with nausea. For which they went to a near.
CABG was done. How many? CABG is done.
Yes, CABG, no PTCA done.
PTCA.
For which they went to nearby hospital and supportive care was given. And following with the continuous pain was there, and CT chest was taken and CT abdomen.
What is the type of pain?
So dull aching pain, more towards the right side of the chest.
Right side or
Left side of the chest, sir.
okay.
And also more towards the diaphragmatic region.
Okay.
And it was continuous type of pain, sir. And it all the days it was progressive in nature. Initially, pain was mild type, and over the days got progressed.
What does this pain indicate?
Sir,
So visceral pleura is basically
Pleurisy or pleuritis. How do you differentiate between the pericarditis and pleuritis?
pleurate is when the patient is inspiring, and then when the lungs expand because of the irritation, patient will complain of pain. Pericarditis, it is there pretty much
There's
all
the
the
patient
time.
to hold the breath for a while. So the pleural rub, that will be disappearing. Once the patient starts breathing, it will be heard again. But unlike this one, even after withholding the breath, the pericardial rub will be had. Okay.
okay.
And this will be increased with deep inspiration, cough, any straining, all this will increase when it's pleurity.
And from there, a CT chest and abdomen was taken, which showed malignant lung mass with heterogeneous lesion in the liver, and was referred to AIMS for further management. Sir. And there was a general examination, sir. He was a moderately built and nourished patient. There is no pallor, icterus, clubbing, lymphadenopathy, cyanosis, and BP of 130 over 80 with saturation of 94% maintained room air with a pulse rate of 88 and respiratory 20 per minute. And systemic examinations are respiratory system. Air entry was decreased on the left side, and normal vesicular blood sounds are here. And also in the GIT, there was no acid tenderness noted. Patient was complaining of pain, but no tenderness was noted on the abdomen. And CVS and CNS system was within normal. We run the lab parameters, sir, which showed a total count of 9,000 and also CRP of 26. And other values were within normal limits, sir. And later on, patient developed breathing difficulty as we continued, and later we took an X-ray which showed left-sided haziness and also.
So when you are taking an X-ray in a patient who is having pleural effusion, we have two problems. One, we can have stable patients with pleural effusion. You take an X-ray, what will be the finding? If you take the same patient in an ICU where the patient cannot sit up, if you take a AP view, what will be the finding? So these are the problems in emergency room. So you are getting a pleural effusion. You are taking two types of X-ray. One is AP view, another one is PA view. Like how do they different? APVU is the most important thing because most of the patients coming to ER will not be able to stand, or when they go to ICU, they will not be able to stand. We have to take only APVU. So how do it different from a PAVU X-ray in a pleural effusion?
So when the patient is standing for a PA view, then in that case, since it's a fluid, you'll be able to see the blunting of the CP angle,
Okay.
the LS curve, everything can be found out. But when the patient is on a portable X-ray and the patient is lying down supine, in such X-rays, since it's fluid, the fluid will be spread all over the lung parenchyma. So we see a diffuse homogeneous opacity.
Ground glassing. Okay.
Ground glass.
So when you are taking an X-ray in ICU or if the patient is unable to stand up, if you are seeing one side full white color, then that is possibly due to pleural effusion. It can be minimal or massive. We don't know. So in that case, you are likely to miss the diagnosis of pleural effusion. You may make it as some collapse or consolidation or massive pneumonia, something like that. So in a lying down X-ray, it is very difficult sometimes to localize that pleural effusion lesion. Okay, so you have to be very careful when you're asking for X-ray. Instead of that, you can go some other investigation in ER to find out pleural effusion. What is that investigation?
Following that, we did a bedside ultrasound also,
Okay.
which showed free fluid in the.
Okay. So in X-ray is good in a clinical settings where there is no ultrasound is available. But if ultrasound is available, that is a better tool than X-ray to make a effusion, especially in bedridden patients.
Yes. And the diagnosis of pleural effusion was made, most probably secondary to the malignant lesions. He was already been outside CT was showing the features suggestive of lung lesion.
Okay.
And
CKD patient. Huh?
no, sir, no CKD. And USD later on our lab our emergency USD later on we had a radiological examination which showed heterogenic lesion on the liver segment also, sir, associated with large cystic areas in epigastric region and left gross pleural effusion. And following which we did a MDCT which showed a left gross pleural effusion in the lung lobe with in the left hemidiaphragm with mass effect and shift to the opposite side, and also liver showing lesions. And we were for further management, patient was having decreased breathing difficulty was increasing as such, and we decided to go for a thoracentesis and just to
What are the indications for thoracentesis in a patient who is having pleural effusion from emergency?
in emergency settings are indications are if the patient is having respiratory increased respiratory.
Only if the patient is having respiratory distress, we have to tap in emergency room. Otherwise, you can take time and shift the patient to ICU or ward. There you can tap. Okay. What are the conditions you tap fluid?
For diagnostic and
One is for diagnostic and the other one is therapeutic. Okay. Suppose a patient who is having cardiac failure coming with pleural effusion, he is having breathlessness. What do you do? He is having pleural effusion, but he is having cardiac failure. That also can sometimes produce pleural effusion because of fluid overload. Or patient is having nephrotic syndrome and he is having pleural effusion, but he is having breathlessness. How do you tackle the issue?
so if we treat the underlying cause, it will resolve by itself.
How do you control the problem now in ER? Like a patient who is having nephrotic syndrome, he is having bilateral pleural effusion, he is having breathlessness,
It will recur, sir. So
he is having anemia, bilateral pleural effusion. How do you manage?
you can tap.
You give furosemide, Lasix.
Yes.
So in a patient who is having volume overload and pleural effusion, which is causing breathlessness, Lasix is the treatment, not tapping. Tapping should be done only if the cause is unknown or you want to make out a cause. Like a patient is having cardiac failure, you treat the cardiac failure. And Lasix is the treatment for most of the cardiac failure induced volume overload. Nephrotic syndrome, you know that it is hypoalbuminemia, but volume overload should be tackled. Anemia, volume overload. The Lasix is the treatment for most of the conditions with pleural effusion. But here it is due to malignancy. We have to tap and find out what is the type of fluid and whether it is due to malignancy infiltration to the pleura or some other condition like TB or pneumonia or some infections. Okay. So you removed fluid.
Yes, sir.
Try to remove fluid.
Removed
What should be the position of fluid patient to remove the fluid?
uh,
Ideal position.
we can do the in a sitting position, sir, with hands raised above shoulders, and the site at which we use the is the called triangle of safety with the anterior border of pectoralis major and posterior border of latissimus dorsi, and uh, the lower margin is in fifth intercostal space.
Okay.
And we usually do mostly in the fourth or fifth intercostal space in the mid axillary line, and it is usually done under the ultrasound guidance, sir.
If that is all done when you have a free fluid, in tuberculosis and all, you can get encapsulated fluid or cystic fluid spaces. In that condition, this area of triangle is not recommended because we don't know where is the fluid. Sometimes fluid may be accumulated on the upper part. So again, ultrasound guided fluid tapping is the best way of tapping because we can see the problems under ultrasound and tap it.
The patient has to be kept in a comfortable position because it's going to take a couple of hours before all the fluid is drained out. So ideally, the patient has to be put on one side of the bed and supported by a table rest, and the patient has to be leaned over the thing, and chest has to be expanded so as to provide.
Then you
support.
infiltrate the lignocaine. Okay. What are the immediate complications you anticipate when you give lignocaine?
One neurovascular bundle can get injured, sir. An accidental injection can be given either to the any of the vessels like the arteries or the
Normally, we tap, we draw the syringe and see whether blood is coming out, and then only we'll infiltrate. Even then, there is a chance of directly injecting the lignocaine to the vessels. That sometimes it can produce a problem.
So the ideal safe area is a upper border of the lower rib.
What are the other common anticipated problem while initiation of the tapping?
Common problem: one patient can end up with pneumothorax.
Initiation means you are putting a needle. Immediately, what will happen? Most important thing, pain-induced hypotension. Some patients can develop vasovagal syncope only because of your tapping. That's why whenever you are tapping, you should be able to if the patient develops hypotension, immediately put the patient in a lying down supine posture and lift the leg. That has to be there. Okay, so that is a common adverse problem can be generated by your needle prick. Okay, then after that. Then she told it can inject directly into the vessel. Then
Then pneumothorax can be
pneumothorax can be there. Okay.
caused. Or sometimes when we are putting it, it can even injure the lung parenchyma.
Okay, that leads to pneumothorax. Okay, then
And adjacent organs. Left side spleen, splenomegaly ruled out.
Right
Right
side
side
liver.
liver. Okay.
so other injuries very rarely it can happen, but when you are doing ultrasound guided, these things are very less. Okay.
And then people can even put guide wire inside.
Guide wire. Normally we don't put guide wire into the needle. No, very rarely. When we are tapping, we are only using the larger needles. We don't put guide wire, but the guide wire can sometimes go inside. You have to be very careful if you are using a wire with tapping.
And large amount of, if it's not monitored, patient can have hemodynamic instability, go into hypotension, and large volume of fluid can be drained out, which can lead to expanding
Pulmonary
edema.
Re-expansion pulmonary edema. So large volumes, if you are removing without proper care, patient can develop re-expansion pulmonary edema. If the patient develops re-expansion pulmonary edema, what is the treatment?
Same, just like any other pulmonary
Yes.
edema.
Okay. Just chop the tapping. Whatever fluid is remaining in the syringe, put it back. Put the patient on supine posture. Start him on BiPAP ventilation. Okay. NIV is the treatment. Like any other pulmonary edema, Lasix can be given.
And then you can also cause infections later on stage.
Okay. So if you are not tapping with proper precautions, infections are possible. Then on tapping the fluid, evaluating the fluid, how do you know that it is exudative or transudative?
Lights criteria.
What is Light's criteria?
Lights criteria shows us whether it's exudate or transudate. It's upon three points. If serum pleural protein to serum protein greater than 0.5, or pleural LDH to serum LDH greater than 0.6, or if the pleural LDH is more than 2/3 of the serum LDH.
So main thing is LDH and protein. If it is more than 50% or 60%, it indicates it is a exudative. Okay. What are the causes for exudative pleural?
Exudative is more infective pathology, most probably. And
Bacterial, viral, fungus, TB, all this.
malignancy.
Okay.
And transudative most probably occur used to heart failure.
Volume overload conditions like cardiac failure, liver failure, kidney failure, nephrotic syndrome, anemia, and polycirrhosis. So many conditions can have this one. Okay. Bilateral pleural effusion causes
Malignancy.
malignancy normally produces initially unilateral, like this patient. Later, when it spreads to opposite side, it can have bilateral.
Or any of these serositis.
Polycirrhosis and failures, like whatever failure we discussed, and polycirrhosis. SLE is one classical condition. We can have polycirrhosis. Okay. Now, what happened to this patient? So this patient is having pleural effusion coming to emergency room. We should intervene only if there is respiratory distress. Otherwise, we should not try to tap in emergency room, because tapping, we need to take care of the patient like in a ICU or in a controlled environment. Emergency room is not a good place to tap unless until there is respiratory distress. When we are tapping, patient can develop complication like pneumothorax, hemothorax, hydropneumothorax. So many conditions can happen. Okay, so we have to be very careful. After tapping the fluid, what all things you have to do?
The fluid should be sent for cytological investigation, sir, and
So immediately you have to send the fluid. You should not keep the fluid for longer period because it can degrade all the cells in the fluid. So take the fluid, send to lab. Only one condition you can keep the fluid there. What is that condition? You want to see whether cobweb phenomenon is forming, whether the RBC is in that settling down or not. That you want to observe, you can keep up. But investigation wise, you have to send it fast. Okay, will AFB will be positive in pleural fluid, acid fast partially.
Unlike
TB?
no, sir.
TB is not an direct infection in the pleural fluid. Okay, it only produces a reactive pleural effusion. So AFB is not required to be positive in a TB pleural effusion. Okay, there are some other investigations are available like ADA. What is ADA?
ADA shows
Adenosine deaminase. More adenosine deaminase, more than 40 international units tells you that it's possible TB. Okay, but we have to do other investigation also to rule out TB. Okay, so investigations are very important in getting a fluid from patient. But here we know the diagnosis already that it is a malignancy. So we have to see whether malignant cells are there. But still in malignancy you can get TB. Okay, that is a problem of TB. TB can be there, superadded infection can be there in so many infections, malignancies, HIV. So you have to do TB test also. What else, sir?
Okay, sir.
Any anesthesia?
So regarding anesthetic drugs usage, there are two entities in this patient. One is pleural effusion, one more this thing is age of the patient. So accordingly, what are the drugs and how will be select and administer? So most important thing is don't choose any drug which will cause further respiratory depression. And always these people will be usually have full effect with smaller dosages, smaller intermittent dosages, and then titrate to the need. Okay, if it is massive, so massive, we have to first tap the fluid and then try for an intubation. Okay, don't straight away go for the intubation. Okay, these are the important thing. And what is the agent of choice which will cause the least respiratory depression?
ketamine.
Ketamine is in smaller dosage is enough, and short acting drug is better, and simultaneously keep about the organ dysfunction, especially liver and kidney, whenever you are choosing any drugs. And this patient a cardiac problem.
Sorry, sir.
She was on any anticoagulants.
Yes, sir.
So that also before tapping, starting itself, you should keep in mind. There's a prolonged bleeding chances may be there. Okay, I have a bleeding profile done, and I have a baseline knowledge about it.
And the comfortable position will be when the patient will be lying down on the affected side of the lungs.
Okay, patient for routine lying down. So affected side only we have to make the patient. If you put on opposite side, what will happen?
The fluid will.
It can compress. It can compress even the opposite side. The massive pleural effusion with collapsed lung can compress the opposite side. That's why whenever the patient is admitted to your ICU, make the patient on same side. Like right side pleural effusion, patient should lie on right recommended position. Okay, it's right decubitus position.
The pain is on left side. When he is lying down on the left side, there will be a splinting action. The chest will not move. I mean, the other side, the chest will move more. Most pain.
Okay. Thank you.